Just do it in a minute.
So we're going to try to give just a brief history for those of you who may not be as familiar with Smoky Mountain Center and its relationship in the community. And then Ann's going to talk a little bit about things that have happened over the course of last year. And then if we have a couple of minutes left, we'll talk about what we anticipate coming in the future. Can everybody hear me okay in the back? Yeah. So Smoky Mountain actually started in 1965 as a local mental health program, and then in 1972 was known as what was a local management entity and serving the 7 westernmost counties. And then over time, we've grown to 23 counties. In 2012, we became responsible for managing the Medicaid dollars, as well as serving as insurance for people that don't have any other type of mental health insurance, and then also managing public dollars that come through the county. And we serve all 3 disability groups, so if someone had a mental health treatment need, a substance use treatment need, or if a person had an intellectual or developmental disability and needed services, they could get services through Smoky Mountain. As many folks know that have been anywhere near the system, there has been a lot of change and transition. We went from kind of local community mental health centers to then we went into something called privatization, which the idea behind that was to give people choice. But what they found in many rural communities was what that really did was limit service availability. And so over the past decade, there's been quite a bit of work done to try to stabilize and ensure that even in small communities, that the range of services were available for individuals who needed treatment or who needed support services if they had an intellectual or developmental disability. So as I mentioned before, we currently serve 23 counties, so all the way out to the Cherokee County and probably our easternmost county is Wilkes County. We served this year about 1,561 individuals on the Innovations Waiver. For those of you who are familiar with the old CAP MRDD waiver, that's what that is. And that's kind of the upper end of folks that are trying to be supported in the community that have an intellectual developmental disability. We also serve other people with IDD, and we're not on the Innovations Waiver. And then we've served about over 163,000 people this year on the Medicaid waiver, and then 137,000 people that are not insured. One of the things that's unique about Smoky that's different than any other LME MCO in the state is that we serve more uninsured people than any other MCO. And that may not seem like a big deal, but when you think about the percentages of budgets, it's kind of like your checkbook and the government's checkbook. That's sort of the comparison between state funds. There's very limited state dollars, and then Medicaid is a much richer benefit. There's a lot more dollars associated with it because it's an entitlement. When you think about Smoky, in the old days we used to be a service provider, and then today we've become responsible for managing the network, or managing different private providers across our counties to ensure that there's at least one comprehensive care center and availability of a full continuum of services for both adults and children in every county to have some level of service. In most counties we're able to pull that off, but in some of the really tiny counties, I think sometimes Swain certainly feels this, or Graham feels this, they don't always have the same number of services, but there should be a service place that gets next door, like in a Cherokee County. Macon County is actually really well represented for the amount of mental health services that they have. When we started a while ago, coming back from having privatized, there was a real challenge with having adequate children's services. Today, there is a combination of what we think of like the traditional services, where you see somebody in individual therapy, basic benefit. There's also services that go out into people's homes, like intensive in-home for children that have really high clinical needs. There's services like day treatment in the school system now, and I can remember when that used to be a really bumpy thing. Threaten that stabilize their services in the school to help support children in that way. There's also intensive outpatient that serves adults who have high needs with substance use or substance dependence, and a variety of other things. It's not a perfect system, and there will always probably be more need than there are resources to serve every single individual in the community. But we've always believed that the way that you do this is you leverage your partnership with your community partners. And so we've worked really closely with juvenile justice, with social services, to try to identify children and families early in the process to try to keep them out of the crisis services, because we know that's where a significant burden comes in the county, is when you have people that get kind of stuck in the system, end up in your emergency department, Sheriff's Department is spending a long time with them, and we're trying to actually get them into an inpatient hospital bed. And that is an area where we don't have the number of hospital beds or inpatient stabilization services that we usually have. We're building to expand capacity in that. We have a service called facility-based crisis, which is hopefully one of the things that you try to do before someone goes into an inpatient setting. Sometimes you can't always stop somebody going through that. But facility-based crisis for somebody who doesn't need an absolute most acute clinical service, that is a place that can help someone stabilize who's having a really difficult time. And there's going to be another, we have one in Balsam. There's another very large facility that has a very different capacity level that is now being built and developed in Buncombe County. There's an additional facility-based crisis coming up in Caldwell County, and you might be thinking, man, that's a long way away from Franklin. And get stabilized and then return home to their home community where they can get wraparound clinical services. That's a much better outcome than ending up getting shipped across the state. It's better for the person who's in the process, and it's also better for the community partners that we have that have to bear the burden of cost for transportation instead of the city. So that's kind of the nuts and bolts pieces. I think when you think about Smoky, we're a public entity that functions like a private organization, kind of like a public hospital or a public university. We do still touch community members. We still work with consumers. We just don't provide direct services. And I'm going to let Ann share a little bit about what some of the things are where we actually do a little bit more community and hands-on service contact.
So one thing that not everybody knows about Smoky is we do spend a good bit of time doing prevention and education, kind of outreach activities. We teach a lot of classes around the catchment area, and they are offered at no cost to community members. We teach classes that help people learn about mental health and mental illness, and in so doing, help to destigmatize those topics. One of them is mental health first aid and youth mental health first aid. I think I recognize a couple people that were in that class a few months ago. We teach something called the community resiliency model, which I think pretty soon we're going to have one here. That's all about building resiliency in communities, so teaching some really simple but very effective stress management to people, and then teaching them how to teach that to others. So you come take the class, you learn some skills, and then you go home and you tell your friends and family about what you learned, and everybody has better coping. You don't have to be a therapist, you don't have to be a doctor to learn the skills or to teach the skills. So that's one of the classes we enjoy teaching, and several others. Well, another one is the WRAP class, the Wellness Recovery Action Plan, which helps people maintain their recovery and make plans to be in recovery as long as possible. So I think that's sort of the gist of it. But Smoky is really committed to the prevention side of things, to the education side of things. We believe very deeply in the potential for recovery for most people when help is received early, and we believe in communities being able to really support one another. What Rhonda was mentioning about people ending up in the emergency department, sometimes that could be avoided by earlier intervention. So things like mental health first aid, where we learn to support each other way earlier, so maybe the hospital never has to happen. But thank you.
How many minutes do we have left? 6. We're doing well. So in the last piece of that, we have Smoky also, because we started in small communities, and particularly in the Western, one of the commitments that we also have is that we have community-based staff in every county, regardless of the size of the county. And the reason that we did that is as many of you guys know, as businesses get larger, sometimes it can be really easy to lose touch with what's happening out there. And so there is actually a commitment to have people, the clinical staff as well as community education staff, in those local communities to be able to stay in contact and in connection with the local providers in each county, and also with the community stakeholders that are part of the team in helping support and identifying where are gaps, where are problems, where do we need to fix, what do we need to put in place next, is this working, is it not working. And I think what we found is that when you have people out there, listen, we're going to start telling you, We'll tell you more often than not when it's not working, but you also gives you a chance to see what does work well. I think in the future, for those of you who are following the news, there's a lot of discussion about the role of mental health and what's coming. There are things called accountable care organizations, which are related to the Affordable Health Care Act. And I suspect that is probably one of the next big political conversations. What that really means for the community is that Medicaid costs, if you listen to, regardless of your politics, Medicaid costs have continued to climb nationally for over the last decade. You cannot sustain an entitlement service budgetarily in that way. And some of the reasons that costs are climbing is because we've not been particularly efficient about care. Systems don't talk to each other. Sometimes you get redundant services, as Anne mentioned earlier. Sometimes it's a person getting into services far too late to where they're already at a crisis level rather than trying to meet someone's needs earlier in the system. North Carolina has stabilized their mental health Medicaid budget costs, and that's a big deal to you as a taxpayer, believe it or not. But we haven't been able to stabilize the Medicaid costs because currently the way that is funded and the way that is contracted is very different. There's a thought that if you put responsibility and made, just as they made LME and COs responsible for the Medicaid dollars, you made an accountable care organization responsible for physical health care costs, and you matched that up and partnered that up with behavioral health care, so that's mental health, substance use, and IDD services, and you put those two things together. Wouldn't it be nice if those two systems talk to each other and work together and actually plan care around the person, rather than having to go to 13 different people with 13 different plans with all these different things trying to manage it when you're already at the most stressful place in your life. And so there is a financial accountability and risk management accountability for that. There is a discussion going on right now with Smoky Mountain, with Mission Health System, and with MAHAC, because MAHAC and Mission cover the majority of the counties that Smoky also covers. And so there is discussion about a collaboration for if in the future, if some things change at the legislative level that would allow the state to do this, would we be able to then move into more of an accountable care organization where you begin to blend physical health care and behavioral health care together to have a more unified system rather than trying to treat somebody like partner over here, partner over here, partner over here. So that's what we are expecting. It's not a done deal. As you know, Ronnie, I'm sure will talk a little bit about this, that there's a lot of politicking going on right now, and there's a lot more to go in that. But I think the ultimate goal, and I think the thing that our system, regardless of where the politics fall, is our focus is going to be on whole person care. If you haven't managed your diabetes, if you're not sleeping right, if you're killing yourself because of some of your health choices and habits, you don't feel well physically, that is going to impact how well you do with your mental health. Vice versa, if you're depressed or anxious, you're likely to do some things and not take care of yourself in the same way that you would if you felt better about that. Or you might be using substances in a way to cope that you might not normally do if you were healthier in a different place. So it's all about finding that balance. And so that's really going to be the long-term goal of our agency is, regardless of what the politics or how those play out, how can we support a person to move across the system so that they have basically one plan of care that looks at both the health side and their behavioral health side.
And it was.
I get an extra minute.
You can have our minute. You can take it.
I give it to Ronnie.
Ronnie will take it.